briefly at the start, and I then will pass over to our excellent panel. I just wanted to, I'm Ingrid Young, and I invited the guests to this panel today because I thought it was really important to talk about race and racism in sexual health in Scotland. It is something that affects quite a number of people, but is often something that is not talked about, or people find it difficult to talk about. And we recognized in the program that it wasn't really an issue that was flagged up very much of it all. We also recognize that there is an issue of capacity. People who work or are affected by these issues might not always have the time or the ability to submit things like this, to submit kind of presentations on this, or find it a safe environment in which to discuss this. So we really, as a conference organizing committee, wanted to spotlight this as an issue that is absolutely essential to deal with or address in sexual health and social justice in Scotland. And so I'm really, really pleased that the panel has agreed to join us today. Just a brief reminder of our terms and conditions and our zero tolerance policy. We won't stand for any abuse or attack, and we will encourage you to attend this and listen and engage in a spirit of active listening and discussion and respectful debate in order to address the challenges that we face. I'm going to be quiet now and pass over to Mildred Zimunya, who is going to be our chair, and Mildred will introduce the rest of the panel. So thank you very much for joining us.
Thank you very much, Ingrid, for that introduction. So yes, I'm going to be chairing this session. My name is Mildred Zimunya, and I will speak a bit about myself once I've just gone through a round of introductions of the speakers. So just going on a random pick, once I've picked you, could you just pick the next person to introduce themselves? Okay, just make it a bit interactive that way. So I'll start with Ima. Ima, could you just introduce yourself and then pick the next person, the next speaker, please? We can't hear you, Ima.
Sorry about that. Yes, hi, thanks Mildred, thanks Ingrid, thanks for the opportunity to participate in this session. I am a community engaged researcher. I work broadly within migration and with those who are marginalized and racialized from within ethnic groups. I work across portfolios with Scottish Government ministers, civil servants and policymakers, and really have been engaged with that over the last 20 years. Says unprecedented migration has changed Scotland's demography. I'm really within this broad framework. It's sort of frame it as anti-racist practice, and I think I'll talk some of that as we develop. But really work across health, education, the cultural sector, and skills and employability. So I think that's probably enough about me. So thank you. Shruti.
Hi, everyone. My name is Shruti, and I'm here as chair of the board of directors for Sahelia. Sahelia is a mental health and wellbeing support organisation for women and girls in Edinburgh, the Lothians, Greater Glasgow, as well as other parts of Scotland. I do this work in a voluntary capacity because it's important to me. And I've been working in and around women's mental health for just under 20 years. For my day job, I work in public health, and I do that across 2 roles right now. And I'm here on behalf of Sahelia because I felt it was an important conversation for us to be part of. It has been difficult to release staff to come here as they deliver frontline services, but really glad to be here as part of this important conversation, and would like to thank Ingrid for the invitation. And I'm going to pick Dale.
Thanks, Shruti. Yes, my name is Dale Taylor-Gentles. I'm the project coordinator for the Black Health Matters project at the Love Tank. The Love Tank is a health promotion and health education organization that's primarily focused around sexual health. And the Black Health Matters project, which I run, aims to address health inequalities that impact Black communities across the UK by working with people who have lived experience of those health conditions from a variety of health conditions. And we're trying to work with people across the UK in both city and rural regions. And I nominate Idris.
Hello all, my name is Idris Akormadu. I work for Upenyo Health and Wellbeing Project as a funding officer, and we provide support for Black ethnic communities in Scotland living with chronic health conditions. And I will nominate Hosanna.
Hi, my name is Hosanna Bankhead. I'm from Zimbabwe originally. I came here almost 20 years ago, and I found myself getting involved in sexual health. Not from my own doing, but I just, it was one of those things that happened. And I've been involved with it for the last 20 years, since 2003, because I found myself not well and I was diagnosed with HIV. So I'm a woman living with HIV. But what I then realized as I was navigating the system of HIV in Scotland, I realized that there was nothing culturally sensitive for the people of my color, African people. And the one-size-fits-all system was not working too good for me, and I really struggled. So it's basically about my journey, and that's how Upenyo came to be formed. And I've been part of it. Now I'm not really part of it. I am still a trustee, and I've worked for THT, I've worked for HIV Scotland. So yeah, that's about me, and I've retired, by the way. I'm thinking of doing a PhD. Hopefully I'll do it. That's my story.
Oh, thank you very much, Hosanna, and thank you for all the speakers for introducing yourselves. And I'll just say briefly about myself. I have a background in public health, addressing health inequalities, but also a background in sexual health and HIV. I started on this journey back in Zimbabwe, where I was a nutritionist, and my focus was really around HIV, sexual health for mothers and children. And at that time, there was no treatment for HIV. Then I moved here to Scotland, and it so happened in 2006, I got a role to work with Waverley Care to develop a project looking at Africans and their needs in terms of sexual health and HIV in terms of support. And so that journey began with just scoping out what that would look like for Glasgow. There was something that had already been started in Edinburgh. So we started that very small in terms of what we were doing, but the work quickly grew. As you know, when we deal with African communities, there are so many other social needs that come into play. So the project quickly grew into a lot of things around peer support for mothers, around support for men, around access to condoms, around working with faith leaders, around how they can communicate and broach the taboo subject around sexual health and HIV. So I worked on that for since 2006 up to 2018. And then I've left Waverley Care, and I've continued on that journey, now looking more at the needs of African women. We co-founded a women's group called Sharpen Her. And there again, we see all the inequalities that play out and affect communities. I'm also part of the anti-racism working group and a trustee of Korra Foundation, which is looking at the funding side of things, how funding impacts on the needs of grassroots organizations and how they can deliver. So how is funding structured? How does that impact on how people access it, and how does that impact on what people can do for their own communities? So that's the other background that I'm bringing to this today. The other part of it is around research, how research is shaped. And for that, I work with Ima on the SMEARS committee, where we look at research and how research is done and what is brought out in research and what that means in terms of the communities that are impacted by that research or whatever research is taken, and what sort of actions come from that. So that's part of my other hat. So I'm bringing all this to the table, but more with a focus on how that impacts on people around sexual health. So to start it off, I just had 3 things that I wanted to say around how racism contributes to health disparities. Because some people might say, why racism? But for me, it's more than just what it does in sexual health. It's really what racism does to health. And there are 3 things for me where that interacts. There's the institutional platform, where we see a lot of practices and systems that negatively affect access to services. Then there's another layer for me that's about unconscious bias, where we see how healthcare providers might hold preconceived notions about people who access services. And then the third aspect for me is that aspect of internalized racism or self-stigma that we carry because of how we feel we should be so that services can understand us. So I come from that background of those 3 layers of how racism impacts on us. So it's something around institutional racism, about our unconscious bias in terms of the services that we receive, and the third bit being about our own self-stigma that we hold in terms of trying to be acceptable in these things that we interact with or the services that we interact with. So I'll leave it on there because now we are moving into our 3 questions. And the first question really that we are posing to our speakers is, how does racism affect sexual health and well-being in Scotland? And what are the key challenges for communities of color in Scotland today? So that is the question that we are wanting just to hear from our speakers. So probably I'll just pick on Ima to start us off on this one, the first question.
Hi, thank you for that, Mildred. And yes, it was interesting to hear all the work that you have done over the years. I guess for me, the idea about racism in health, I mean, it has been such a fight in Scotland to even get it to recognize about what is racism in health. So some people who know of the work that I've done over the last few years, sort of which culminated in bringing Professor Williams to speak through GCPH, who really has spent 30 years, a global scholar, to identify and evidence, who has evidenced the racialized disparity and inequality in health. And I think it's the reason for that was because the system operates, sexual health operates as though there's a real risk of kind of race science, that the ethnic variations in which are evidenced sometimes in our research and processes and service delivery are because of ethnicity and individual cultural issues, and not related to systemic racist processes which play out in people's lives, in their health, in their job applications, in their education, in housing, in all the systemic process which were shown in the pandemic to be the reasons behind why those who are racialized and minority ethnic groups are more at risk within the pandemic. And so that was just highlighting what exists in sexual health, in my view, is just as equally, it's certainly no difference. And I think just one other thing to say about that before is that my understanding is that traditionally or usually within sexual health mainstream services, there is no attempt to even collect ethnicity data, and we can come back to that. So you're saying about the impact of racism, the whole thing is infused with such enormous systemic kind of lack of understanding of in relation to minority ethnic communities, to individual people, about how the systems that we function around in research and service provision So I'll leave that there for now, a bit of a blast right into it. But, you know, Professor Williams told us very clearly and evidenced very clearly the huge impact of racism on people's health, and sexual health is within that landscape.
Thank you very much, Ima, for that. Anyone wants to follow up on or follow on what Ima has just said there, or add any other comments regards the question?
I can come in, and I think I can build on both what Ima and yourself have said, and just the different layers of racism that people can experience here in Scotland. So what we found through our work here in Sahelia is that our women just aren't getting the service that they're entitled to. So sexual and reproductive health services are too generalised and they don't meet their needs. And this is because there is that real lack of understanding of what is needed for women. There could be a generalisation of what the needs are. So some of the women that we work with have been on significant journeys, and some still are on those journeys. They've experienced significant trauma, and they require not just one service, but maybe multiple services. So there's a real lack of understanding of what is needed, but also the complexity of what is needed. As you've both raised, there are barriers to accessing services at every level. And when women are already extremely vulnerable, some, like I said, have experienced significant trauma, any delay in accessing the services can lead to complications, both in the short term and in the long term, and even death. But, we do what we can to support women in the community at the grassroots, and we provide support to access mainstream services to help them overcome some of those barriers. And even if they are able to overcome some of those entry barriers into services, they then go on to experience cultural insensitivity, as you've both raised. We all know there's fear and mistrust in the services. But as Sahelia, we've been working on this for nearly 30 years, and we've been raising the issues with mainstream services for this time, and it's just not getting through. So there's like a real lack of willingness to kind of listen to what some of the issues are and to want to kind of make a change, and to the capacity to be able to kind of take that on board. So with that lack of understanding and willingness to kind of take that on board, there continues to be those barriers. And they're very general ones, that we always see, like around interpretation, for example. So we feel that we are being ignored when we come using our voices with the mainstream. But most importantly, it's the needs of the women that we work with that continue to be ignored. And this is, public services are supposed to benefit everybody, but there are the deep inequalities that exist in the service provision, which are just exacerbating those health inequalities. So it's I think we all know this around this kind of table already, but it's dire, and it's, for me, what's really concerning is that when we're raising our voice, we are not being heard, and that's allowing the racism within the system to continue. It's not being taken on board, the issues that we're raising.
I would like to add to what Shruti has said. I totally agree that as a group of people, we are not being listened to. And as far as I'm concerned, putting everyone in one basket and calling them Bame, I think it's really unacceptable. Because if you take an African woman and women from sub-Saharan Africa and take an Indian woman, our experiences are very different. They might be similar, but very different. And the way we are socialized is totally different. So the term Bame really doesn't augur well with me, because I find it, what do you mean? Who is the Bame there? What are you talking about? Because we are not all the same. And secondly, until we deal with systematic and structural racism, which exists in the environment that we are living in, we can come to these panels, we can talk, we can do all sorts of things, but the structures that perpetuate it and the systems that perpetuate it, if they are not dealt with, we are just going to continue talking. We are going to continue having this conversation. And thirdly, my third thing is that there's no money given to us. If you come up as an organization, and I'm talking from when I started Hupenyo, there's that sense of not believing that you are doing the right thing. You don't know what you are doing. We can do a better job for you because you are an African, you don't understand. And I think that is very patronizing, and it makes you feel like you are inadequate, you don't understand what you are doing. And when they give you that money, it's a shoestring budget. So you find a lot of these Black organizations in Scotland are running on shoestring budgets. They do not have money to look after their own people, and yet they are doing the right thing. And it just makes me quite upset and frustrated. And then people say I'm a Black angry woman. Yes, I am a Black angry woman when it comes to that.
Yes, you are raising some very, very, very strong issues and very historical issues too, Hosanna. I don't know if anyone else wants to comment on what Hosanna has said in terms, and also what Shruti has said about being listened to, and also the whole shoestring budget. But also, I think for us, there's this whole issue around culture and cultural insensitivity that's emerging, and how does that play out for sexual health services? Anyone want to come in on that point? I don't know, Dale, do you have any points you want to make on that?
Yes, I suppose I can talk more to the UK as a whole, because the work that the Black Health Matters Project does is around looking at health inequalities across the UK and not specifically to sexual health or to Scotland. But I think you mentioned, Mildred, and Hosanna mentioned that a lot of these issues are historical. As we saw during the COVID pandemic with the virus, that it disproportionately impacted Black and Brown communities across the UK. And we know that those inequalities didn't arise just from the pandemic. Those are because of historical inequalities that have existed across health, across the UK for generations. We know that, for example, within reproductive health, Black women are 3 to 4 times more likely to die during childbirth. We know that Black and Brown communities across the UK are more likely to have STIs or STDs because of lack of access to the health services that we need, or lack of targeted campaign to support these communities. So there's a lot of reasons why how racism is playing out in terms of healthcare and sexual healthcare.
I picked a key point there that you said, targeted campaigns. Do you want to say a little bit more about that in terms of targeted campaigns? Because this is, I think, an issue that it's a double-edged sword almost. But could you share a bit about your views on that?
Yeah, I think it was a point raised by a few of the other panelists earlier as well about the fact that there's a lack of cultural competency both within. Oh my gosh, sorry, I've just had my door ring. It's a problem when you're working from home. Sorry.
It's all right. You can go in and we can pick it up when you come back.
Yes, sorry.
Yeah. Anyone want to pick up on that one?
Mildred, I would just come in. I wanted just to reflect on what had been said. We're talking about racism here, and we're saying about, because we all here know hugely on and over again the same issues again and again. But I think the point that you were saying about, I think it was Hosanna was saying about the level of funding, the access to funding, what the funding is for, and because it doesn't look like what the system actually would traditionally give, so then there's distrust. But of course, the point is that the thing is to look different from what the system would traditionally give. And so I think these things are really problematic. And I also, just about the ideas around systemic racism, and Dale just mentioned it there about the maternal health statistic for Black women, so that 1 in 5, you're 5 times more likely to die in childbirth. But the solution to that has been to, supposedly accepted by NICE, is to induce Black women at 39 weeks. And so to me, that is really problematic. That is systemic racism acting right now actively in sort of health solutions, because of the perception that it's something biologically inherent and not related to the systemic racism in the system, and then the system enacts it. So I think these things it's an incredibly live issue. The damage and harm that's going on is becoming understood. I mean, we couldn't even talk about racism in health if you kind of put up an event, in sort of mainstream services. People were not able to hear it. So we're finally talking of the issue directly, right? The discrimination or inequality or equality and diversity or whatever. So we actually are talking of the issue, which is racism in health.
Yeah. No, thank you very much, Ima, for those points. Maybe just to get back to Dale on your point, which you had started to make. Are you there, Dale?
Yes, I'm here. I completely lost what the point was.
So you spoke about the targeted campaigns, and I was saying that's more like a double-edged sword in terms of how that's received. So what has been your experience of that?
I think we can use COVID as one example of targeted campaigns. We know that Black communities tend to be quite distrusting of health services because of our experience of racism and discrimination in health services. And then I suppose so when you do targeted campaign, I suppose that can help to build that trust back or break down some of the cultural stigma or the cultural barriers that might be there, as well as address some of the issues of racism within those healthcare services. But the double edge you're talking about, I suppose, is that when you start to target a particular community around health issues, then I suppose that actually might play into the distrust that's already existing there. So then the questions that arise about why is the campaign targeted at us? Why do we need it more than other communities? In my own work that I've done with my colleagues in our organization, where we've done stuff around sexual health and like outreach work in spaces where like Black men tend to go to around gonorrhea testing. Some of the questions we tend to get are why are these campaigns targeted at Black men as opposed to just men in general? And then when you even explain the statistics around the fact that particular communities are more likely to contract these, are not getting tested enough for some of these conditions or these illnesses, that I suppose it only feeds the fear and the distrust that's already existing there. So I suppose rather than getting through the barrier, actually just adding an extra layer to it when you try to target a particular group in terms of campaigning or work you're doing.
Yeah. What do others think about that? This comment that Dale has just made.
Yeah, I think what you guys said makes a lot of sense. I think it all comes from the unwillingness to see Black people as individuals. I mean, one of the approach that in my very short time of exploring this topic, one of the approach I continue to see is the diversification of materials or printing out materials in multiple languages, and that's meant to sort of create equal access to some of these health provisions, but it doesn't. The issue here is the mindset that a lot of this the systems has, a lot of the mindset that a lot of clinicians have, and we should be aiming to decolonize that as opposed to printing out materials in 3 different languages and giving it to people.
Thank you very much for that point of view, Idris. I'll come to you, Shruti, on this one around materials. What has been your experience? Because you talked about interpreters, and again, that's about language. That's about understanding, the services. What's your kind of comment on that?
Yeah, I think from our experience, we found that what we see is 1 or 2 actions or a series of very small actions, and there are actions that are so for like say information, for example, that might have been developed, but without real input from communities and from the experts, which are communities. So, there's issues around the whole process around how some of this information is developed, and then how it's just disseminated as if communities are going to listen to them and follow them. But, these are just like one-off small actions, just like some of the targeted campaigns. And what we need to see is it's that big systems change that we really kind of need to see, and a series of actions and a series of serious bits of work. Otherwise, we're not really going to begin to dismantle all the processes and the systems and projects that are taking place that are really going to affect and create the change that we need. I just feel that these things are good, but in isolation, they're not really going to deliver what is really needed to deliver services that some of the women that Sahelia come to. They're just things that are tinkering around the edges and not really making much of a difference. So that's where I kind of sit on that one.
Thank you very much. Thank you very much for all your contributions on this first question.
Mildred, can I just say, just before you go, the Professor Williams in his seminar that he explained, was replying to Dale's point about why specifically that the enormous risk, I can't quite remember, it was absolutely staggering. I think 1/3 of childhood deaths, young child death, maternal death, sorry, of childbirth of the child, I mean, was 1/3 greater if you did not have a physician of color. That the levels of engagement of people who in services, if they were not seeing themselves represented in the services and who they provided, and the knock-on effect of that into your health was, I mean, he's measured this over 30 years and enormous evidence of the harm, the lack of representation, the lack of staff being there. So the issue of targeted campaigns is not just about the targeted campaign, but much beyond that, to who is providing the service, does it reflect it, all those issues. So I think the seriousness of this, I think, into the public health landscape perhaps needs to be strengthened. Thank you.
No, thank you very much for that point. When you were saying that, it just reminds me especially of the maternity care of a number of cases where I've witnessed myself, especially with Black and ethnic minority women, how their pain, just the sense of pain, understanding the pain levels, where someone had, in one case, they ended up delivering in the lift to the delivery room just because the nurses did not realize that the pain or this person was experiencing was that she was actually nearly delivering. And it's these things that I remember just about a few weeks ago, someone had a big boil under their arm, but because they're dark-skinned, it didn't show any changes in their skin color on the surface. But I suppose if that was on a white skin, that would have been immediately like emergency service. So there's a lot of lack of understanding, even these things about pain and how people express themselves when they are in pain, or what that means, even if someone is holding that internalized stigma about their right to access services and how they play out when they present themselves into the health service. But I'm just going to move us straight to the next question, which is about what are some of the good examples of work that is currently being done to address racism and these key challenges, and what can we learn from them? And I think I will lean towards Hosanna, because you've done some good work around this. Could you just say a bit more maybe about the examples from your own background and experience?
I think as Ima said, one of the things that's really, really important is to walk into a place of health and see somebody who looks like you, and they talk to you and they understand where you're coming from. Because as far as I'm concerned, I'm just not a number, I'm a human being. So when I walk into a clinic or whatever place I'm looking, people should just not see this Black woman, like I was described by one woman that, oh, I saw this tall Black woman and I was wondering what you are going to do to me, because there's that stereotype of them being afraid of Black people. And I thought that was a very strange comment, but that's what happens. And it would be nice to walk into a place and see someone who looks like you, who understands what you're going through, like the lived experience of what you're going through. It's really important. And people want to put it like it's not important, but it is important. If you meet somebody with the same lived experience, if it's gender-based violence, you walk into that organization, there's someone who's gone through gender-based violence, and they're telling you exactly what happens, and they look like you can relate to them because you understand where they are coming from. And culture plays a very, very important role in health. If people want to dismiss culture and say one size fits all, you're going to lose people. People will stop engaging because they feel they are not being respected. And I really do believe it's important that culture be taken into account. I'm not saying we are not that many. I was looking at the statistics this morning of Mami in Scotland. We are not that many, but I'm sure something can be done to actually try and accommodate those kind of things like culture, language, which are some of the barriers that happen when we go into these spaces. So that's where I'm coming from. And I really think it's important to look at an individual as an individual, not as a number, and not to look at the stereotypes. Some of those stereotypes are quite damaging. Some of them are true, but the majority of the stereotypes are very damaging. And people need to unlearn some of those stereotypes.
No, thank you very much. You are raising very pertinent points there around finding someone like you in a service, which is something that we've witnessed, obviously, in some of the work that you do with Upenyu and the peer support that goes on there. And I suppose I can lean on to Idris to talk about some of that from your experience.
Yes, my experience, though it's very limited, it's one that I found to be quite powerful. And on my first day of opinion, I was introduced to a couple of colleagues who worked in the women's group, and it's a safe space where women can bring their different experiences and talk about it in an open manner. There's also the massage therapy that is given by a female staff member, and that's also done in a safe and confidential way. And sometimes it's used as a therapeutic session as well, because the body holds a lot of trauma. So yeah, it's fantastic. Outside of opinion as well, I have very limited knowledge of other organizations that do the same thing. One of them being the Saffron Project in the South Side. And it's a housing association, I believe. It works alongside with Southside, and it does a lot to provide a safe space for people of different cultural background. They may be escaping gender-based violence or arranged marriages or different things like that. And yeah, they also have staff members that are bilingual and of different cultures. So that's something that has always been shown to be quite successful and quite powerful for service users.
Thank you very much for that interest. Anyone else want to come in on this point around some good examples of work that is currently being done to address racism?
Yeah, I can jump in from my point of view. And I think, one of the things that we need to do is to look at where some of these decisions are being made and who are making some of the decisions, and also who's involved in some of the discussions as well. So kind of at the policy level and some of that kind of practice development, service development level. I think that's how you might describe it. But what we've been doing at Sahelia is we have a series of 3 programs which takes some of the women who might come to us on a journey where they end up being advocates and their own community advocates. And they go into Parliament and they talk to MSPs. We've recently extended an offer to the MSP for mental health following a visit to our offices in Edinburgh last Friday, to say that when he's developing his work and his portfolio on mental health, if he needed any expert input from women in Edinburgh through the Sahelia service, then he should absolutely come back. But, a couple of years ago, the Champions for Change, as we call them, took some time to understand their rights. They gained confidence and they learned about advocacy. And they did some advocacy in the Parliament, and they made a significant contribution to Scotland's work on FGM and the creation of the FGM bill. we've recognised that it's important to have, as many women of colour involved in these discussions, but that can be really hard for an organisation like us because it's not something that we get funded to do. We get funded to deliver services and to pick up the fallout from the mainstream, essentially. But it's important, because there is a focus on kind of racism in health right now, thanks to the work that Ima's been leading on nationally. So we've carved out a small bit of money to create a new post, and that's a lady called Paveen Ahmed. So she can go to some of the tables and she can talk about the issues that we experience systemically as a third sector organisation working in this space, but also provide, the stories from the work that we do directly into policymakers and politicians, and it's to begin to develop some of the understanding around the complexity that exists across our communities. As Hosanna say, we're not just one homogenous community, but also the complexity of cases that exist, and therefore the complexity of services that need to be delivered. I think that there's a real lack of understanding sometimes around what some organisations do. People think that what we do is drink tea and eat biscuits. We do a bit of that because that's part of our welcoming service. We do so much more. We don't do low-level intervention work. We do the work. And I think until people really grasp that kind of complexity and level of work, there isn't really going to be that kind of recognition for what, third sector organisations do, but also that shift in power and therefore a shift in resources. So, that's a little bit about what we're trying to do. I still think there's a long way to go in the mainstream for them to really understand the need to move towards system change and anti-oppression and anti-racism work. There's, we're at the start of that discussion. I feel that we're at the start of that journey. But we're doing all we can as an organisation at Sahelia to be part of that conversation and whilst feeding in, stories and our own expertise and experience, and whilst also trying to be at the table as a voice as well. So, I do think there's probably going to be a lot of work that's happening down in England that Scotland could learn from. I feel like England might be slightly further ahead on this than where Scotland is at. And I think that we possibly shouldn't try to do something new, but we should look elsewhere to see what has worked and what hasn't worked, and to build some learning from that. And of course, adapting to our kind of own kind of local and national circumstances here in Scotland, because we do have a very different kind of context and climate. But we shouldn't seek to reinvent the wheel. There's a lot of expertise out there, both in Scotland and Scotland's communities, and the organisations that work with communities, but also, down in England, I think we can build on. So that's just a little bit of what we're trying to do, but I feel there's still a lot more that, mainstream needs to do. And I think we're at the start of that journey.
Yeah. And anyone want to follow up on?
I'll just come in there just from what Shruti was saying there, because of course, this idea, like Scotland's, it's so new to the ideas of, it's an immigrant country, not an immigrant country. And so it behaves like with surprise constantly. And so when you say that question about good work, of course, loads of community organizations have been doing good work. We've been doing good work forever. What I was trying to think of is, can I think of any kind of organization that took on the ideas of racism, mainstream organization, and actually have started to embed anti-racist practice, or even to think about or to engage what that even looks like? Can they name it? So that's a bit of a struggle. So the community organizations have been doing good work forever. I mean, that's just a given. But it's hard to think of in that organizations which have kind of grappled with the reality of what is systemic discrimination related to racialized people and what that really means. So I feel that Scotland, is coming in, like it said, England has a different history with this. Scotland has come in, and then the pandemics happened when there was a global moment of kind of reckoning and understanding, at least for a minute, that what this was in reality for people's lives. and how that manifests into their health, into their sexual health, into their education, etc., etc. Where we're at right now, I would say, is like, well, what are you going to do with it now that you've seen it? What are you going to do? And so I'm working hard in that space. But you know, this is it. And I say to the sexual health landscape, well, what are you doing about it? You saw it too. Like, it shouldn't be on us to like say, what are you doing? You saw it as well. So a bit of a call out there.
Can I just jump back in? Sorry, Mildred. I hope that's okay. But you know, I feel like I'm being a little bit harsh, but you know, there are some organisations out there who are taking on that anti-racist ideology. And I think it's, you know, I do a part-time secondment with the Glasgow Centre for Population Health, and it's something that I've done since March. And we've managed to, you know, the board have just signed off that you know, it will do everything it can to explore and to become an anti-racist organisation. And it's taken 6 months for me to do that, you know, to kind of have those internal conversations and to explore it with the board. And the board are committed to it. And you know, the next challenge is to begin to put that into action. You know, there's always challenges, there's lots of little hurdles, but just to have those conversations in that space is great, and to have it kind of signed off at a senior level is really, really great. And you know, what they will try to do is to begin to unpick some of their research practices, and in you know, in the context of kind of being anti-racism, and that's, you know, it speaks, I think, in a way that you were talking about the work that you're doing with Korra, at, you know, Foundation, Mildred, and it's, you know, it's great to see this beginning to happen. And I like to think that once one organisation sees another organisation doing it and talking about it, then they might think about doing it as well. But I still see, you know, I see small steps of action, and I'd like to see bigger steps, you know, bigger patches of action. And I feel that we're just at the start of that little movement. So whilst I felt like I was being a little bit harsh in what we're saying, you know, there is some good work that's starting, but it's slow. It is a little bit slow.
Yeah. I'd just like to second GCPH as an organisation, what Shruti was saying there, which has absolutely taken this on in a level that I would have not seen any other public health organisation try and grapple with that, and that kind of modelling of how to bring in and how to engage with that. I think there's others in the cultural sector who are also doing this. And I think, you know, and also in education as well, there's sort of key, small, usually pivotal organisations who can influence their own kind of sector. And these are really important kind of tools. Young Scott too, yeah. Okay.
Thank you very much for raising those. And yes, Shruti mentioned Korra. Some of you might know Korra Foundation, and we do a lot of funding from Scottish Government and funding dispersal. But the process of application, we are looking at how that can actually open up to people accessing the funding, being able to access the funding, being able to apply for it, not it being a daunting process, but also internally looking at our processes, what has been happening, how is our staffing, how does that you know, pan out in terms of how then we respond to applications that come our way. So reviewing all that. So I think the same as what Shruti is mentioning there, it just reminds me that there is a lot of work to be done, but also the onus should not just be on Black and minority ethnic people pushing this forward. It needs to come from the other side as well. And I think this is the biggest message that I can say. The burden should not be on the victim. I think this is, if we can call ourselves victims, but I wouldn't want to call myself a victim as such. But in this case, we are the affected. And oftentimes we are now expected, especially in the racism sphere, to come up with solutions. We need the solutions to come up as well from the other end. And I don't know if anyone else wants to come in there with any other examples as we move on to some of thinking about priorities. What do you think some of the priorities can be in terms of how we address this, especially in the sexual health fora?
I think one of the key priorities, and I think it was mentioned by Shruti and Hosanna earlier, is having the right people in the room. So although I agree with you, Mildred, that it shouldn't be on the affected communities or the I suppose those on the receiving end of racism to do all the work. I think it's important that people that are the people with lived experience of these issues are actually in the right spaces. Often it's decisions being made for communities where the community is not being consulted, and that's where the issues arise. I think Ima mentioned earlier around like how pregnancy mortality is being addressed and it's leading to more racist practice. So obviously in that instant that the right people aren't being consulted around how we address these issues. I think that's probably one of the key priorities, actually having the right people making decisions around policy and addressing these issues. So having actual lived experience, people on the receiving end.
Thank you very much for that, Dale. Any other comments in terms of what our priorities could be?
Can I jump in? Sorry.
Yeah.
So I think representation is really key, and I like to think more of it as representation rather than getting lived experience around the table, because there can be a tendency to pick and choose lived experience or maybe kind of frame it in the context of a case study. And there's something around having just more than one person around the table. It needs to be 2, 3, 4, because that's when you can start really having a discussion. And just remembering that point that that we need to recognize the diversity within the diversity as well. So often in my day job, I'm often the only ethnic minority in the room, and people look to me for the answer to speak on behalf of all communities, and I feel a huge amount of pressure to deliver. And I just say I cannot speak on behalf of all communities. I've got my own privileges. I was born in England, and all that kind of stuff. So I think there are ways and means of kind of getting the expertise around the table, but to kind of shape some of these services and develop them. But I fundamentally believe that expertise exists in the third sector, and it's about bringing the third sector to the table and sharing some of the power with the third sector and sharing some of the resources as well as getting representation in those decision-making roles as well. So that's that point in representation. The other point is around understanding. We need to build our understanding. And, one of the ways that we can do that is to develop the data that we have. And there is a lack of data in Scotland, full stop. And it needs to be better. And it needs to be much more sophisticated and nuanced. But also recognizing that that some of that data and that expertise again lies within the third sector. But certainly from our point of view at Sahelia, we sometimes feel a bit uncomfortable handing some of that data over because we often haven't been credited for that data, use of that data. We find that sometimes when we write reports in response to grants that we've received, that information has then been taken to develop this, and this, but there's not been any credit given to the organisation. And that's knowledge and expertise that we've built up over 30 years, and it's not to say that we won't share it, but there's something around not abusing the trust and kind of abusing the power that's there. So there's something around there's a bit of broken trust there sometimes with the system from our part. So that's part of the systemic issues around some of this. So we're not saying that we won't help and we won't get involved, but we've been burnt a little bit. So we're just a little bit cautious about how we engage and who we might engage with. I've dropped a few points in there, so I'll stop now.
Thank you for that. Yes. Any other points that people want to conclude with here? Ima?
I think the issue about data, in particular in the sexual health landscape, is really important. I mean, data, there's a massive push going on, partly caused by the pandemic and the fact that Scotland wasn't able to the data wasn't adequate to determine the increased mortality or morbidity of those who are from minority ethnic backgrounds in Scotland. So there's been a massive acceptance that is an issue and sort of moving forward. But the sexual health landscape is in itself of particular significance because people can correct me on this, but as far as I know, they don't, like many of the mainstream services don't collect ethnicity data. And so you don't know whether the services are being effective in that way, even those projects may well do. So I think that is something that really seriously needs looked at. And and then, but also then within the data, how the data is used, because Scotland has a really long history of struggling to realize why we collect ethnicity data. We collect ethnicity data to understand the inequalities that are being experienced by those from minority ethnic, not to ascribe ethnic variations to particular issues. And I think that issue is only just beginning to be understood in Scotland. So again, there's a serious piece of work there for researchers and academics who are creating the research with or without communities to understand what they're at risk of doing in that. So I think there's some serious risk. And also just the mentioned, Shruti was talking there about representation, lived experience. So I'm great for it, think it's a great idea, but there's such a long history of that relationship being challenging. And so I very much argue that you need the experts who understand the dynamics of those relationships and the power to be in the room to support academics and policymakers, not just hear the issue and not know how to manage that through their own system. So I am absolutely for that people are there, but that you need people with expertise to help navigate what is being heard, who's saying it, and how that lands into research, both proposals and interpretations of research, but also into policy and service decision making. So there's a lot of learning that's going on, not just around racism, it's the same around genders, it's the same around ableism and classism. And so there's a lot of rethinking going on in society, which, this is part of.
Okay, thank you very much, Ima, for that. Any last comments on this before we wrap this up? We've got only 3 minutes. Okay, so thank you everybody for your contributions to this session. And we just hope that things will play out differently in terms of practice, that we will be listened to, and that there will be structural, systematic change in terms of approaches. And also we hope that access to funding to deliver some of this and trust to deliver some of this will be accorded to third sector grassroots organizations who are doing a lot of good work. So on that note, I would just want to thank everybody. And I don't know if Ingrid is around. Oh, she's...
Yes, I am. Thank you so much. Thank you so much, Mildred, and thank you to the panel. This has been, you probably could have stayed on for another few hours to talk about all of the things, and there was so many nuggets that you've dropped that I will have to go off on Google now. But can I encourage people to complete the polls that we've just published, to just take 30 seconds to respond to what you thought about this session, so it helps us to understand if this was something that you want us to follow up further and to feed back to the participants. But can I just say thank you to the participants for your time. I appreciate the time that you have given to us for this, and we hope that it was worth your time. It was certainly a benefit to our conference, and so I just wanted to thank you so much for that, and so for some excellent chairing, Mildred. We'll get you to chair lots of other sessions in future.
Thank you.
So thank you very much,
everyone.
Thank you.
Yes.
Thank you.